Hey there, class. Welcome to your lesson one. We're going to do an anatomy and physiology intro. We've segmented it down to a digestible portion for this first video. It shouldn't take very long, but it is required that you watch it. There will be test questions on here that I only say through the video portion. I hope you're all having a great day, and I'm ready to get started. Yes, it is an energy drink, but it's better than a cocaine habit, right? So I'm gonna go ahead and start sharing my screen here. And there it is. So A&P warm up. So we're gonna warm up with just a little A&P stuff. Me and Mr. Larry are gonna be throwing these lectures together for you guys. And of course, as you watch them, you may develop questions. And that is the beauty of the flipped classroom, is you can write them down. You can send us the emails or whatever you really have to do to get this thing answered. You can Google it yourself if you wanted. We're going off of the A&P material that we have, and it is the most up to date. That doesn't mean it doesn't change. The thing about medicine is medicine does change. The human body hasn't changed much, but it's very likely that you could find something contrary to what we say. If so, please bring it to our attention and we can provide clarity. All right, so let's warm up. Brace yourselves. A&P is coming. All right, so as an introduction, we need to talk about anatomy. There are several different types of anatomy, anatomy is the study and the structure of the makeup of an organism. Who's the organism? As you, as me. So we're going to be studying what's called gross anatomy. Microscopic anatomy, this thing could get super complicated. It could go all the way down to the atomic and molecular level. We're not going to go quite that far for just an introductory EMTB course. Of course, the more you know, the more effective provider you can be. But again, like I said in the orientation, if you was there last night and called it, communication is not the key. I always thought it was, but it's actually comprehension. Being a paramedic on scene with a bunch of firefighters or other people who have maybe a lower level of medical training than me, if I say, hand me that super long, supercalifragilistic word over there, and they don't understand what I'm saying, I'm only creating more chaos on the scene. So with that being said, I have to speak in terms that people understand. But the language of medicine, to speak to a doctor, to give report to nurses, you're going to have to understand the language of medicine. And as far as your registry test is concerned, they're not going to ask you, hey, is this patient's having difficulty breathing? They're going to say dyspnea. So understanding anatomy, physiology, and medical terminology is going to be of utmost importance for you to be successful in this course and with passing your certification exam and your career as an EMT. All right. So we're going to be focusing on more of a gross anatomy. The goals of what we're going to be doing are going to be very simple. We're just going to make sure you can identify structures, anatomical terminology, landmarks, things like that. Because if somebody's, let's say you get a call for a stab or a gunshot to the upper right quadrant of the abdomen, you know what the upper right quadrant is and what structures and organs are behind that. So we'd be talking about the liver or the gallbladder at this point if it was upper right quadrant. So this is why we have to learn this stuff. And again, guys, I want you to take this seriously and don't try and skim ahead on me. Don't try and just fast forward the video here. This isn't like your college, I took art appreciation last semester and, it was fun. I enjoyed a lot. And I actually do look at art now. I did appreciate the class, but this is a lot higher stakes. I admit that this is a lot higher stakes. Somebody's life could be in your hands and you want to be as knowledgeable and competent as an EMT as possible. So take this seriously and take the time to do the work here. There are 168 hours in a week's time. I'm asking you to give me 8 of them. Give me 8 hours a week dedicated to this, doing your homework, your discussion boards, your tests, and you're watching your lectures and making your lecture notes and making flashcards. There's really nothing better than flashcards. So getting started again, we're going to be focusing on the gross anatomy. So physiology is the study of the processes and the functions of the body. So how the body works and why it does the things it does. So homeostasis, this is an important term. The state of balance in which organs and systems can function effectively. The body wants to work correctly. It's always got a system of checks and balances going back and forth, balancing itself to work in an inline neutral way. And the pathophys that we're going to talk about is a study of the functioning of an organism in the presence of disease. How does the organism, you, the person, function in the presence of this disease? Why is that important? Well, I gave an example last night about, let's say we have a patient that calls us with an asthma attack. Well, asthma is more complicated than I'm making it, but it really is a disease of excess mucus production, inflammation, and bronchoconstriction. All right. So we in EMS would then address those three issues because I know how the organism, the human body, responds to an asthmatic attack. I know that the bronchioles are constricted. I need to deliver a bronchodilator or a beta-2 agonist, some kind of medication that will take that constricted little bronchiole and blow it up so you can breathe again. So also the inflammation, that inflammation is swelling. That swelling will collapse and close that bronchiole, that tube which you breathe through in your chest. So we got to reduce that inflammation with a glucocorticoid steroid of some sort. So these are the reasons we need to understand the patho behind these disease processes and how it affects the human body, because we want to be able to help and know why we're helping. It's okay to know, and I want you to know the how and the when, but I need you and want you to know the why. That for me will help you understand and retain this information for a lot longer. So there is systemic anatomy and regional anatomy. For this course, we're mainly going to talk about systemic anatomy. The systemic approach we will use because it studies each organ system separately. While our beginning couple weeks here is going to be kind of like a big A&P overview, when we hit cardiology, we're going to go back over the heart anatomy again and study it singularly. And when we hit respiratory emergency, we'll go back over the lungs again and study that physiology and that anatomical structures again too. And the goal is we're going to try and have a pluck lab for you guys, which means we're going to try and bring in some pig lungs and heart, and we're going to let you look at them in their glory, sitting there on a table with some drop cloth down. You're going to see them. There's going to be blood and heart. We're going to open the heart, dissect it. That is the goal for us here. We just got to find a way to store it. We're working on that though, but it will happen. And that'll give you a good bird's eye view of some of that systemic anatomy. But we're going to break it up into pieces so it's digestible. If I took you to a buffet and overfed you, you'd throw it right back up. That's why we've broken this thing down into digestible blocks. Each week will be a block of information. You got the whole week to digest that information. You've got homework and unit assignments that will also help you retain that information by forcing you to recall these facts for a written type of quiz. All right, so just an overview of the body system. I remember telling you that it can go deep, like it can go down to an atomic, molecular, macromolecule level, organelle kind of area. Kind of where I want to start talking to you guys is the cells. The cells become tissues. Cells make up tissues. A bunch of skin cells together make skin. The tissues will grow together and make an organ. Organs will make organ systems like your digestive system, your cardiovascular system, circulatory system. And those organ systems will go on to make the organism, which is you, which is me, the organism. So the overview of the body systems that are included are going to be skeletal, muscular, circulatory, lymphatic, immune system, respiratory system, nervous system, gastrointestinal system, urinary system, reproductive system, endocrine system, and integumentary system. So when we talk about topographic anatomy, we're going to be doing this to identify superficial landmarks to make accurate assessment. Everything we do in EMS is based on a strong assessment, because I don't just prophylactically just do things in an exploratory way. As a paramedic, I have the skills and training and authorization. If I find a patient to be symptomatic with a possible air trapped in the chest, a type of tension pneumothorax, and it's starting to put pressure on their great vessels, I can stab a needle in their chest and relieve that air pressure. But if I don't know landmarks, if I don't know how to make accurate assessments, I can't just willy-nilly stab somebody in the chest for an, well, maybe they've got a tension pneumo, I don't know. Well, I guess they didn't. We don't just do exploratory medicine. We base everything we do off of accurate assessments. Something you'll probably hear me say a lot, and some of my students, make fun of me for saying it, but it's like, My dad worked on houses, so he taught me a long time ago that you need to measure twice, cut once. So doing a quick and accurate assessment is great, but also being double sure before you do any kind of big interventions that could be a bit invasive. That would be to the benefit of your patient, because the first rule of medicine is to do no harm. The first rule of medicine is to do no harm. If you are watching the videos, that will be on your quiz this week. So that is the first rule of medicine. We're always going to want to try and do no harm if possible. Sometimes the interventions we do can hurt and be uncomfortable, but it is to prevent the greater evil. It is to, help, save, rescue, or whatever it is to make the patient have a better outcome. I know this hurts, but it's better than death, right? Sometimes it is a life over limb type of situation. We're going to learn about anatomic positions. This is important because anatomic positions are universal positions and from which all body positions and movements are described. So when you're describing anatomic positions to a doctor, he'll understand what you're saying, but also when you're charting it, you'll be able to write it and understand it yourself, or reading. Some of you will be working for the 911 agencies. Some of you will be working for the transport agencies, at least starting off, or that might be where you like to hang out. And if that's the case, you'll pick up patients that are already, semi-stable, but maybe not. And when they do that, you'll have to get a report from the nurse, or I would say, or both, read what the charting says about the patient. It will be written with anatomic positions. You'll need to know why they have this patient sitting all the way up. So these are important things to understand as well. Ooh, label me like one of you French girls. Part of what A&P is being able to label things. So that will be some worksheets we'll probably work in with you here in a little bit. I thought this was kind of funny though. All right, so let's start off with the anatomic position of what we got here. So the universal position is when the subject stands upright, like the gentleman here in the picture is doing. He's facing the observer with arms straight and palms forward. If everybody wants to take a second, go ahead and do that and stand like that guy. That is the universal position. The reason he would stand that way is so you can actually start and look at and make your assessment right there. We use directional terms to pertain to the patient's left or right. The directional terms that we use always pertain to patient's left or right. Hopefully you all know left from right, so this will be quite an easy transition for you. All right, next we're going to talk about the planes of the body. The planes of the body. The frontal plane, also known as the coronal plane. Sometimes in medicine, there are 2 or 3 different names for certain things, and it's important to know all of them because we're not sure what one registry will test you over. So we want you to be prepared for all aspects of that exam so you can be successful. I want you to be successful so we can be successful. That was a line from The Incredibles 2. It really stuck out to me because it really described the team dynamic. And I want you to be successful so I can be successful, so we can be successful as a team here, because we are in this together. You are your brother's keeper. And like I said last night, there is such a shortage of EMTs and paramedics right now in the state of Georgia and across the nation. Guys, how bad would it be if one of your loved ones needed an EMT or a paramedic and they called 911? There's nobody to answer the call. I'm glad you guys have taken the initiative to answer that call. You've taken the steps towards being in this career field, and we need you bad. We love you, but we have to make sure that you're squared away and you know what you're doing, because we can't have you out there hurting people. So take it serious, work hard. Frontal coronal plane divides the body into front and back. Front and back. That's how you remember it. Divides it into frontal plane and back. The transverse, or the axial plane, divides the body into top and bottom. So from the midsection up and the legs down, that divides it into top and bottom. Everybody's got that so far. The cool thing about I like this part about it, but the great thing about having a lecture PowerPoint that's been recorded is you can always rewind me and hear me say it again until you got it. I myself am taking university style classes right now, university level classes right now, and I gotta say, I have an Achilles heel for math, and it's whooping my butt. But you know what? I can rewind that lady and rewind her until I get it. Even I can get it after like the 5th time. So you have that option as well. Then we have the sagittal plane, which divides the body into left and right. Left and right. So sagittal plane does what? Splits left and right. Divides the body into left and right. Mid-sagittal divides left and right to equal halves. So some directional terms we've already learned. Frontal, also known as coronal. Transverse, which is also known as axial. Sagittal, also known as lateral. Now, superior, when somebody feels like they're superior, they feel like they're over you. So if we're going to say superior, it means that something is closer to the head, closer to the top. So let's say my shoulder is superior to my hand. It's closer to my head. So anytime we hear the term superior, we're talking about something being closer to the head. Now, inferior would be something closer to the feet. If somebody is inferior to you, they're below you. Just kidding, seriously. So my knee is inferior to my pelvis. That's how you remember these type of things. And sometimes I have taken, years ago, but I took exams just like you're taking. I'd be in the classroom like shoulders, it's higher than my elbow, so it's got to be superior. I'm not above that. Hell, I still count on my fingers and toes. So whatever works. It ain't stupid if it works. All right, more directional terms. We're talking about medial now. Medial means toward the midline. The midline is if I split your body down the middle like this, all the way down. That's the midline. And that is important because we need to know if things are moving more towards the middle or if they're moving more towards the outside. So medial is more towards the midline. So if I have an injury on the inside of my elbow, I have an injury on the medial portion of my elbow. If it's on the outside of my elbow, it is more lateral. It is farther away from the midline. So medial is closer to the midline. Lateral is farther from the midline, away from the midline. All right, now proximal. Proximal talks about towards the trunk of the body. Where's your trunk? Right here, right here. So if it is something more proximal, it is something that is toward the trunk of the body, not bottom. Now, distal, we're talking about away from the trunk. So proximal means something closer to you. Distal means something farther away. Distal means something farther away. All right. Now, some more directional terms we need to talk about. Anterior always means the front of the body, but again, it has another name. Anterior and ventral both mean the front side of my body. The front side of this area right here, right here. Anterior means the front side of something when we're talking about directional terms in the body. Now, posterior means the back of the body. If I'm gonna kick you in your posterior if you don't pass my EMT AMP exam, so I'm gonna kick you in the back. Also, posterior means dorsal. Dorsal means the back of the body. The way I remember that is the dorsal fin of a shark. It's on his back. So dorsal and posterior both mean back. Anterior and ventral both mean front. So knowing how to say front and back in medical directional terms is very important. All right, we got imaginary lines in the body. We have to know the imaginary lines. These are great for knowing landmarks and locations of injuries and being able to just communicate effectively. So the mid-clavicular line. So where's your clavicle? Your clavicle is over here. All right, this is around your collarbone, okay? So the clavicle, the mid area right there, that is your mid-clavicular line. So going straight down, that would be where your mid-clavicular line. It's a vertical line through the middle portion of your clavicle / collarbone, and it's parallel to the midline. Where's the midline again? Right here. If I was to split myself down the middle, that'd be my midline. So it is vertical line through the middle portion of the collarbone. It parallels the midline. All right, mid-axillary. So that is a vertical line through the axilla to the waist. Your axilla, the armpit. The armpits. You ever heard of somebody taking like a axillary temperature? So they take it underneath the armpits. So that'd be over here. All right, so mid-axillary is right down here, going right there. All right, so anterior axillary. Remember, anterior means front, so that's more towards the front of your axillary. Posterior means back. Posterior also means dorsal. So that is a parallel line drawn an inch or so behind the mid-axillary line. So we got anterior axillary, mid-axillary, and then back here, posterior axillary line. All right, abdominal quadrants. This one's highly important again, because when we ever have some type of abdominal trauma or a patient complaining of pain, based on the quadrant Sometimes based on the quadrant of where their pain is located, we can tell what organ is being affected. So again, patient shot or stabbed in the right upper quadrant, we're talking about the liver or the gallbladder being damaged. All right, so the abdominal quadrant is divided into 4 sections, 2 imaginary lines intersecting at the umbilicus. The umbilicus is belly button. My daughter walked me the other day and was like, Dad, I have a belly button. Like, great job. So you got a belly button or an umbilicus, or some people call it umbilicus. If I say things and they sound kind of twangy and southern, I'm sorry if I'm saying it wrong. But as long as you get what I'm saying, I don't care. So 2 imaginary lines making 4 quadrants of the abdominal. We got the right upper quadrant. Everybody raise your right hand. Hello. Yes, raise your hand. Now put it on the right upper side of your chest, your abdominal gut here, right upper area of your chest. That is your right upper quadrant. Raise your right hand, top of your belly, top of the belly. That's your right upper quadrant. Now, where would my left upper quadrant be? Raise your left hand. All right, top of your belly, right there, left upper quadrant. Now we got right lower and left lower. Where do you think they are? Let's just slide the right hand all the way down to the bottom of the belly. That's left, that's right lower. Now slide the left hand down. That's your left lower quadrant. If you ever get stuck, and it's okay to be stuck, just raise your hand up, right hand, top of my right side of my belly. That's my right upper quadrant. Slide it down. That's my right lower quadrant. Left hand, top of the belly, left upper quadrant. Slide it down, left lower quadrant. If you're ever confused, just do that. And I admit, sadly, that I may have taken a patient's hand and been like, where's your right hand? All right, it's right there. Oh, that's right upper quadrant. Whatever it takes. It ain't stupid for us. So there are specific organs located in each quadrant, and pain or injury can be described as being in that quadrant. So let's talk about it. Your right upper quadrant will contain your liver, your right kidney, your gallbladder, some colon, and your pancreas. Right lower quadrant contains your appendix, the colon, small intestine, the ureter, major veins, and arteries to the right leg. Your left upper quadrant contains your stomach, left kidney, spleen, colon, pancreas. Left lower contains colon, small intestine, the ureters, major veins and arteries to the left leg. And the midline area is about where the aorta is at. The pancreas, the small intestine, the bladder, and the spine. So that's what all those things contain. Now let's talk about range of motion just for a second here. Range of motion is going to be the full distance that a joint can be moved. So how was the full distance it can be moved? We have physiological norms that are supposed to occur. Like, let's say I injured my wrist, and normally I could do this, but if my wrist is injured and I cannot move back like that, I have a decreased range of motion due to the injury. So this is why we want to know range of motion. We want to know what normal values are. Now, I do want to say, be aware of the atypical individual. There are people out here that can bend themselves into pencils. So make sure that's not going on before you do all these tests. I had a guy, he had fell off something and hurt himself, but he took the time to make fun of me a little bit because he had the ability to be very flexible. I'm like, dude, that's freaky. He's like, I do that all the time. So he finally admitted that he was just messing with me, which, you know, I enjoy a good joke. I appreciated him for that. But there are atypical individuals that are outside the normal range of motion. But most of us normal people, we have a normal like range of motion, which is an area that we can do certain things, right? So that is the full distance that a joint can be moved. Now we have abduction and adduction. Now the way I remember these is adduction moves the extremity towards the midline. Where's the midline? Right here in the middle. So it moves me towards the midline. I'm adding to myself, adduction. I'm moving the extremity towards the midline. So I'm adding myself. Now abduction, abduction is we move an extremity away from the midline. The way I remember this is I work chest and legs, deadlifts, and squats. Anybody wants to do abs, I push them away. Go on with it. I just want to do chest and be huge. So abduction, you push away from you. So people that want to do abs, push them away. Adduction, ADD, add to yourself. Abduction, push those people away. That help? I hope so. Abduction, move away. Adduction, move towards yourself. So let's talk about movement now. Flexion. All right, this will be fun for you weightlifters in the class, right? So, fix my camera. Oh, yeah. All right, so a few weightlifters in the class. Flexion is from the anatomic position, moving a distal point of an extremity closer to the trunk. What does that mean? We take an extremity and we move it closer to the trunk. So everybody flex, make a bicep. There it is, mount bicep. There. So when you flex, you bring things closer into yourself, from a distal point out in to yourself. You can do that with your arms, your legs, and your neck. All right, so flexion is bringing things in. So flexion of the elbow brings the hand closer to the shoulder. Flexion of the knee brings the foot up to the buttocks. Flexion of the fingers forms the hand into a fist. Flexion is bringing things in. Everybody with me? Hope you all just made a bunch of muscles and poke noses. I like it. What about supination and pronation? So in the picture B there, we have supination and pronation. So supination, supine is facing up. Pronation is facing down. You must see that? Supination, and it hurts. I got poor range of motion. So supination, pronation. Things that are laying on their face are pronated. We're going to talk more about that here in a minute. Extension. So if flexion is bringing things in, forming a bicep like this, or bringing things closer in, then extension is what? Flexing them, extending out. So flexed in, extending out. Flexed in, extending out. So everybody want to take a second to extend out their arms, or this is a flexed fist, extended. Flexed in, flex my fingers in to form a fist, I extend them out. So in the anatomic position, all extremities are an extension. All extremities are an extension. So there's a nice picture there to show what flexion is with the leg. You flex in, forming kind of a leg bicep on the back there, and extending out is returning it back towards a more neutral position. All right, movements. We got Granny here on the floor. Possible neck position when the patient is found supine. Remember, supine is when you are laying, or you are laying face up. Okay, so she's laying supine. So neutral position is when she has her head laying in an inline neutral position. See the top picture there? Her head is aligned with her spine. Everything's, kind of just in one neutral area right there. Flexion, again, is when her head is poured toward. Whenever you bring it more towards the body, we flex in. Everybody do this. Look down at your belly. Hey, belly. That is flexion. Flexion isn't always making a bicep. Flexion can be done with your legs, your arms, and also your neck. So her neck is flexed there in the second picture of the three. She's flexed down. Now, what about extension? Extension is what? We extend out. So if I throw your head back like this, that is extension. Her head is extended out. So neutral, flexion, extension. I'm going to see my chiropractor. Oh. All right, movements now. Hyper is a prefix added to terms flexion, extension to indicate a mechanism of injury. So when we get to talking about medical terminology, we'll talk about what a prefix is. It sits at the front of a medical term. It gives terms direction, intensity, and can change, what a word's doing. So like hyper means extra, more, too much, right? So if I'm going to hyperflex or hyperextend, like we're going to talk about on this slide, I'm going to look down too much to cause an injury, or I'm going to be pulled back too much to cause an injury in my neck muscles, okay? So hyperflexion, let's take a look. Flexion of not beat number, but the guy over here looking down, okay? The guy over here looking down, he is hyperflexed so much that that red area there at the base of his neck has injured the muscles in his neck there. So he is flexed down too much. And hyperextension is when we come back too far. How about movements now? We have movements. Internal rotation. Let's take a look at the picture here. The patient's left leg is straight and normal, but possibly due to a hip injury or a fractured femur, the patient's extremity, that leg down there, is medially rotating. Remember, medially means it's coming more towards the midline. So medial rotation would mean what? Internal medial rotation means just moving more towards the midline. If it was an external rotation, that means his leg, instead of like cocking inside like that, it'd be going outside. So instead of rotating in, it'd be rotating out. That would be a lateral rotation, external lateral rotation. This is actually a very common call to run at nursing homes. You know, Granny got up and she's trying to run down the hall, see what Grandpa's up to. Hey, baby, what's up? She gets down the hall, she trips and falls, or falls on a rug, and she breaks that hip. And that hip, that top of that femur is popped out of that hip socket. So what's happening? That leg will rotate in or out, and sometimes it'll have what's called shortening. So you can see a little bit of that here. That right leg is rotated medially, and it's also got a little bit of shortening there. So it's a little bit shorter than his left leg, or her left leg. I can't really tell. So external and internal rotation. All right, what about body positions? I admit freely, I stole some of these pictures from, I forgot where I got them from, but I'm not selling this. It's not copyrighted, it's free. So positions we need to talk about: left lateral recumbent and supine. We've already talked a little bit about supine, so let's hit that one first. Supine is what? As you see the Lego guy right here, he's laying flat on the stretcher. That is a supine position. If I have my hand facing towards the heavens like this, that's a supinated hand position. Now, when we're talking about supine position for patients, we mean we got them laying flat on their back. Sometimes that's the position they're comfortable in. Sometimes that's the position they need to be in. Certain emergencies will occur that certain body positions we put a patient in will help that patient's emergency. So a patient that's more supine, that can help a patient that has more of a shock issue, or a patient that's having difficulty breathing. We'll set them high up in more of a high fallows, which we're going to cover here in a minute, to help them breathe. So we got supine position, right? The patient's laying flat on their back. Now we have left lateral recumbent position. Let's take a look at the lady on top of there, or guy, whatever. So laying on their side, the knee stops the body from rolling onto the stomach. Okay, everybody got that so far? Go back. All right, so the knee stops the body from rolling onto the stomach, and the hand supports head. The left lateral recumbent position is also known as the recovery position. That will be on your test. If you watch the videos, you'll catch that. If you're trying to skim past me, you will know it. So head supports hand, knee stops body from rolling onto stomach. This is the left lateral recumbent position. It's also known as the recovery position. One of the reasons we use this position over the years is because it was airway protective. A lot of people we pick up sometimes pretty drunk. And one of the things drunks do is they roll up on their stomach and they puke, and then they breathe it in, and then they die. And that's something we want to actively avoid. So this is a recovery position for patients that we can put them in to help protect the airway. Everybody clear on that? Cool. Now, prone, a body that is laying with the face and abdomen down. So face down, butt up, that is prone. So prone, a body that is laying face down. All right. Now, we don't normally, and even mall cops know this, we don't ever really have patients that we ride prone. There's too many dangers of traumatic asphyxia. There's too many dangers of aspiration, and it just looks terribly uncomfortable. But a couple of times that I had a patient ride prone, it was because that was the only position we could get them in. This guy had fell on a fence and he was impaled, and we were not going to pull that giant spike of rebar out of him. So what we did is we had the fire department come, they cut the rebar, and we transported him and the rebar in the most comfortable position where it's not going to move. Because I don't want that rebar moving and tearing up any more organs or hitting any more vessels. So we actually transported him prone, but we carefully watched his airway. We made sure that he had no complications from that. We called a trauma alert, and they met us at the door. Like, sure, it's a super interesting thing to them. He got rebar all in him. So they met us at the door. They took him to surgery within 15, 20 minutes. It was not long at all. Interesting call. But we do not normally transport patients prone. What about a psych patient? You definitely do not transport patients prone that way. It will cause them to have airway difficulties. And a patient prone cannot expand their chest fully, and they could have traumatic asphyxia and a bunch of other complications. So, but sometimes we do find patients laying prone when we get there. So if we notice the patient is prone or laying face down, we want to go ahead and manage that and get them in a supine position as quick as possible so that we can examine their airway. But we also want to make sure their cervical spine is being taken care of as well. All right, other positions. We're almost done with our first little lecture here. Aren't you proud? Positions we're talking about now are Fowlers, where a patient is sitting upright, and semi-Fowlers. We also have high Fowlers. So Fowlers, a patient just kind of sitting up like I am. High Fowlers are sitting up kind of a 90-degree angle. Semi-Fowlers reclined at like a 45, and then low Fowlers, they're kind of just barely inclined. They're almost supine, but they're not quite. We always put a lot of patients in high Fowlers when they're having difficulty breathing. Low Fowlers and just semi-Fowlers, really, if it's just the patient's comfort at that point, you know, but these are important terms to know. Fowlers, patient sitting up. High Fowlers, sitting up at a 90-degree angle. Semi-Fowlers, 45-degree angle. And low Fowlers, I would describe as probably a 30 or below angle, but not quite zero. Everybody with me? Love it. All right, last and not last but not least, we have what's called Trendelenburg. Now, Trendelenburg is going away here recently. You know, we've kind of traded it in, but I want you to know about it just because it is part of EMS history, and also because I'm not sure what register to throw at you. There are Trendelenburg is where we put patients in a position for that for shock, right? So it's for hypoperfused shock patients. They need more blood flow to the vital organs. So Trendelenburg used to be we'd lower the head and we'd raise the feet 12 inches. We have now traded Trendelenburg for a just shock position. Shock position is patient is laying supine with their feet elevated 6 inches, and that will facilitate more blood flow back to the vital organs. But Trendelenburg has been phased out from what I've been told. So that'd be the last position, but Trendelenburg doesn't really exist anymore, but I'm letting you know about it because I want to be thorough. And now we have just shock position. Shock position is what? Supine, feet elevated 6 inches. Everybody with me? All right, guys, I have spoken. Any Mandalorian fans in the house? Yee. All right, so that's going to conclude lesson 1, just A&P intro, directional terms, and a little bit of range of motion and stuff like that. So any questions, please hit me up, and I appreciate your time, guys, and that'll be that. All right, y'all have a good one.